Thank you so much for watching this today. So we're going to talk about fertility options and as well as ways for you to optimize your natural fertility. My name is Dr. Rashi Kalra. I'm a fertility subspecialist. I'm an obstetrician gynecologist, but I've spent an extra 3 years training mainly in the area of infertility, both aspects, female and male. So today we'll talk about infertility, age-related and other factors, of course. We'll talk about your natural fertility and how to identify your fertile window accurately. We'll talk about treatment options available, and we'll explain a little bit about IVF to hopefully make the process seem a little bit less intimidating if that's what you end up needing. So with infertility, let's talk a little bit about age and other factors. What is infertility? Well, the definition, the medical definition, is for a couple under the age of 35, if they've been trying for 12 months and have been unable to conceive a pregnancy, or the inability for this couple to have been able to carry a pregnancy to full term. In couples where the woman or female partner is over 35 years of age, we define that period as 6 months. This basically serves as a guide for general practitioners and couples to identify when they potentially need the help of a fertility specialist. The reality is that unfortunately there is an impact of maternal age on natural conception, and that really hasn't changed with the times. For women, we're born with our maximum number of eggs, and we lose eggs sort of as a natural process constantly, just like we shed hair or skin cells. The age at 35 seems to be a bit of a precarious age for women, because that's when we start to see a decline in spontaneous pregnancy rates. So for a 22-year-old woman, her chance of conceiving every month is about 25%, not very high. But at 35, that drops down to about 15% per month. And after 40, we're looking at less than sort of 10% per month. The decline in infertility is related to a couple of things. It's related to a decrease in egg quality, a decrease in egg quantity, and also an increase in what's called aneuploidy risk, and that refers to an increase in genetic abnormalities in the eggs that women release. And consequently, that translates into an increased risk of miscarriage. There's always a big focus on female age and fertility, but it's not to say that there isn't an effect of paternal age on natural conception as well. We know that 30% of infertility is related to male factors. Older men take longer to get their female partners pregnant, and this is when we're comparing men over the age of 40 compared to men under 30 years old. We often see subtle differences in sperm characteristics when we assess these men. Some of it is due to an increase in medical illnesses, such as high blood pressure, diabetes, obesity, high cholesterol, and sometimes it can be affected by prescription medications that people have to take as they get older. So it's very important when we're trying to conceive that we optimize not just the health of the woman, but very much the health of her male partner as well, at the same time, keeping in mind that it takes two to conceive. So let's talk a little bit about where things can go wrong, or why it might be taking a couple a bit longer to conceive than they would have hoped. Sometimes it can be a case that a woman doesn't ovulate at all, or not very often, and that can certainly make timing intercourse to conceive difficult. As I mentioned before, male factor fertility contributes to about 30% of the cases that we see in our clinics. A lot of couples will come along and the female is ovulating regularly and the sperm characteristics appear normal, and we put that into the category of unexplained infertility. There are gynecological conditions, some quite common, such as endometriosis or blocked fallopian tubes, that can contribute to infertility. And of course, a topic that seems to be sort of underestimated is sexual dysfunction amongst couples. One of the more common reasons that we're seeing is advanced maternal age and a decline in egg quality that we discussed before. Sometimes with fertility, it's not just one obvious factor, though. There's often multiple minor factors, you know, a little bit of this in the female and a little bit of that in the male. If you look at the numbers here on the slide, you'll see that for a couple with no infertility factors, on average, 80% of them will conceive within the first 3 months of trying. You add in one mild factor, whether it's male or female, and it can take up to 2 years for that couple to conceive. You add in 2 factors, perhaps one male, one female factor, and it can take up to 7 years for the couple to conceive. So it's not always a case that conception is impossible. In fact, that's rarely the case. It's more a case of rationalizing at what point do you move forward with fertility treatment so couples can get to their goal, which is to have a child. It's important to stress that lifestyle is an important factor for both the male and the female partner in the couple. And both need to probably take equal responsibility for that. We know that smoking can affect hormone production, both in males and females. In females particularly, and it can impact the progesterone levels as a consequence of ovulation, and in males it can reduce sperm quality. In terms of more common substances, caffeine in high quantities can lead to an increased risk of preterm birth or low birth weight for the baby, and can sometimes, in rare situations, cause breathing problems for the baby in terms of withdrawal. That being said, this is nothing to get alarmed about. We're talking about an excess of 3 or 4 cups of coffee a day during pregnancy here. So drinking 1 or 2 cups of coffee per day is completely fine. In terms of alcohol, nobody really knows the safe limit of alcohol consumption when you are trying to conceive or during pregnancy. The general guidelines would say for a woman when she's trying to conceive that she should restrict her drinks to 1 drink a day, no more than 5 days a week. The reason being high levels of alcohol, again, can affect ovulation, can affect hormone production in women, and can cause irregular menses. During pregnancy, the safest thing would be to avoid alcohol altogether if possible. For men, again, we know that excess alcohol can actually impact their sperm quality significantly. It can lead to a reduction in sperm volume, sperm count, motility, and morphology, which are 2 of the other important characteristics that we look at when we assess sperm. And therefore, for men, it's important to stick to the guidelines, which say 2 drinks no more than 5 days a week, and that they can't be all saved up for the weekend. In terms of diet and fertility, the general advice would be to have a sort of a complete nutritionally replete diet. Studies have shown that a vegetarian, vegan, or high herbal remedy supplementation doesn't actually make a huge impact on fertility. Women wanting to conceive should ensure they're taking a folic acid supplement, and this should ideally start a month before they plan to conceive. The reason being because folic acid is crucial in neural tube development in the baby. Generally, in women who have no concurrent medical illness, 400 micrograms of folic acid supplementation is sufficient, and that's usually what all pregnancy multivitamins will contain. As mentioned before, best to avoid more than 2 drinks a day when trying to conceive, and to try and stick to less than 3 cups of coffee a day. For men, there is some suggestion that pesticides and lead and industrial microwaves can actually affect their sperm quality. Generally with men, they tend to produce new sperm every 3 months. So, these factors can be modified. And it's important for men who work in these industries to use, personal protective equipment to prevent themselves from being affected by these chemicals. Some studies have suggested that in men who do have mildly impaired sperm count or sperm characteristics, an antioxidant in the form of a multivitamin can actually improve sperm function and even pregnancy rates in couples. So there's probably no harm in a male partner starting a multivitamin. So obesity and fertility, it might sound obvious, but obesity is an increasingly rampant sort of medical condition that we're facing in the Western world, and obesity affects the ability of couples to conceive both through the male and female partner. In women, it causes irregular periods and ovulation problems. It increases the risk of miscarriage, and it certainly contributes to an increase in pregnancy complications when women do get pregnant. In men, we know it can cause low sperm counts, can reduce testosterone level, the hormone that is critical in sperm development, and can actually damage the DNA in the sperm, which then proceeds to become the DNA of your baby. We know children born to obese mothers or obese fathers are at increased risk of obesity themselves in the future. So it's really imperative if the couple maintain a healthy weight and try to bring their weight down when they're trying to conceive. On the flip side, we see more and more women who think that intense exercise and weight loss will actually improve their fertility, and that's not really the case. Being underweight, and by definition what that means is having a BMI less than 18.5, can actually reduce a woman's fertility. A little bit of body fat is actually good for pregnancy. Women with a BMI less than 19 were found to take 4 times longer to conceive than women who had normal BMIs. So definitely calorie restriction and excess exercise in women with normal BMIs is generally not recommended at all because it can affect ovulation. It was actually found in a study that women doing more than 5 hours of intense exercise per week had lower pregnancy rates with IVF. So I'm always telling my patients that they should conduct themselves when they're having IVF treatment as if they were when they were pregnant. Take up an exercise like yoga, Pilates, walking that you can continue doing ideally right up until the end of pregnancy as well. A vitamin that some new research has come up about is vitamin D. Now, there is some emerging evidence of a link between vitamin D and fertility. And some studies, although small numbers, showed that IVF outcomes were better when vitamin D levels were sufficient. The theory is that vitamin D may have a beneficial effect on the lining of the uterus. It may improve cholesterol and blood sugar levels in women with polycystic ovarian syndrome, which is a common group of women that require fertility treatment. And it may actually have some degree of protection against endometriosis. So generally the advice would be if you're vitamin D deplete to replace that with a vitamin D supplement you can get over the counter in any pharmacy. So we'll talk a little bit now about natural fertility. How do we test our fertility? Well, the only test really is to try and conceive. There is no magic test of whether you are fertile or not. Age is probably the most important predictor of the likelihood that a couple will conceive without requiring IVF or any fertility intervention. You might have heard of something called an egg timer test or an AMH blood test. It doesn't actually predict natural fertility, and it doesn't even predict IVF success. The only predictor of IVF success generally is a woman's the maternal age. But the AMH can be a very, very accurate predictor of a woman's ovarian reserves or the number of eggs in her ovaries, and it may help a woman guide her fertility plans. In terms of when to test for fertility, couples with any predisposing factors, the kind we talked about before, such as male factor infertility or endometriosis or polycystic ovarian syndrome, should probably be tested earlier than the 6 to 12 month mark. And this is something that you would discuss with your general practitioner about whether early referral to a fertility specialist is appropriate. So in terms of the fertile window, how exactly do we identify the fertile window and how do we maximize our chances of conception every month? Well, couples always think that, you know, the day of ovulation is actually the most fertile day, but that's not really true. It's called a window for a reason. It's actually the few days leading up to ovulation that a woman has sort of peak fertility. What that means is the sperm can actually live in the female reproductive tract for up to 72 hours. So it's important to start trying a few days before your ovulation date to ensure that the sperm are there in the reproductive tract waiting to fertilize an egg when it's released. So generally my advice to couples when they ask me, how do I assess my fertile window? I say it is difficult to get the exact day of ovulation correct. Generally, in a woman who has a 28-day regular cycle, it tends to happen in the middle of the cycle, meaning 14 days before she gets a period. Ideally, to keep it simple, I tell couples with normal sperm counts to have intercourse every 1 or 2 days from when their period ends for a week, and you should catch ovulation that way. A lot of people might measure basal body temperature, and that can be notoriously inaccurate. I actually believe that slippery and clear vaginal mucus is probably the best sign of a woman's fertile window. So generally I tell couples, don't get too bogged down on the timing of things. It's difficult to pin down the exact day of ovulation. I had a couple once asking me the exact hour. It's virtually impossible to pin that down. Try from day 8 to 14 in a 28-day cycle. And if you're not sure and you have an irregular cycle, then track it. Now, when I say track a cycle, what I'm referring to is blood tests to track, to pin down your ovulation surge, to give you an exact idea of when you're ovulating. Genea actually offer 3 ovulation tracking cycles. You don't even have to have seen a Genea fertility specialist to be able to access tracking. You can actually get your GP to refer you to the cycle tracking. So the first step would be to either book an appointment to see a Genea fertility specialist or download a referral pack on the Genea website and take it to your GP. Generally that website, generally that pack will have a phone number for our ovulation tracking nurse, who will then talk you through the different steps of ovulation tracking. And the whole process takes a month, just like a menstrual cycle does. We normally do a blood test a week after we've confirmed ovulation to ensure that you have a good progesterone rise. And then a week later, we do a pregnancy test. This not only helps you make sure that you're getting your fertile window correct, but it also gives you some awareness of your own cycle and informs a fertility specialist what your hormone levels are like during your cycle. So this slide is a little bit busy, but these are all the treatment options that are available when you potentially come and see a fertility specialist. And they range from very non-invasive options, just like ovulation tracking, all the way up to IVF, which is probably the most invasive, but also perhaps one of the more successful treatment options. Ovulation induction, you might have heard of that, is a treatment that induces the ovaries to produce eggs. Generally, this can be done either in the form of tablets in some women, or it needs to be done through injections. And then the fertility specialist or the fertility nurse will advise the patient when they're ovulating and advise them to have intercourse in the lead up to that. It's generally recommended to women who aren't ovulating regularly on their own. For example, women with polycystic ovary syndrome, or women who have any other hormonal imbalance. In women under 35 who are not ovulating regularly on their own, this is an extremely successful treatment with potentially a 60% pregnancy rate after 3 cycles. There is a small risk of multiple pregnancy or twin pregnancy, and generally depends on whether we use tablets or injections, but your fertility specialist will discuss this with you in more detail. The next treatment we'll talk about briefly is assisted insemination. Here, the woman undergoes treatment to release 2 or 3 eggs potentially, either again in the form of tablets or injections, and her partner's sperm is then concentrated and put into the uterus just prior to ovulation to maximize chances of conception. Sometimes insemination may not involve ovulation induction, and that's dependent on the individual woman's circumstances. The procedure for insemination is actually no more painful than a routine pap smear and is done in one of our clinics without the need generally for an anesthetic, unless women have medical conditions such as vaginismus. So finally, we'll talk about IVF, which intimidates a lot of people. But has come a long way since it was first sort of invented 40 years ago. Generally, in a nutshell, IVF is a process that brings together eggs and sperm in a dish in our lab to fertilize. You might have heard of ICSI, which stands for intracytoplasmic sperm injection, is a more invasive type of IVF. What this involves is selection of a sperm, which is then injected directly into the egg to assist fertilization. This is usually reserved for men who have significant abnormalities in their sperm count, and in these men can be a highly, highly successful treatment. So once the eggs and the sperm have fertilized successfully, they're checked by our scientists the next day. The embryo at Genea is left to develop in our lab for about 5 days, sometimes 6, in one of our custom-made incubators. Generally, you could think about the IVF process in 5 steps. The first step is to stimulate a woman's ovaries to get a good number of eggs, generally between 10 to 15 eggs. The eggs and the sperm are then collected on the same day. The woman will go through a vaginal egg collection procedure under a sedation, and that is mixed then with her partner's sperm in one of our incubators in the laboratory. The next step then is where our scientists take over, and fertilizing and nurturing the embryos in the laboratory happens for 5 days. And the best embryo is chosen for transfer back into the woman's uterus 5 days after her egg collection. During this time, the woman is given what's called luteal support in the form of progesterone, which is usually in the form of vaginal pessaries, and a pregnancy test is performed 12 days later. The next few slides give you a sneak preview of what happens in the lab. So here, this slide shows you the 2 different types of insemination methods. This is IVF, where washed sperm is mixed with an individual egg. We normally would surround each egg by about 100,000 sperm, and you can see those little twitching sperm there. And then we leave them overnight to incubate in one of our custom-made incubators, and we check them the next day to see whether that egg has been successfully fertilized. The next type of insemination that we talked about before was ICSI, which is intracytoplasmic sperm injection. This type of insemination is reserved for men who have low sperm count or abnormal sperm motility or morphology. Here, the scientists will actually immobilize the sperm by using a micropipette. They will actually break the tail of the sperm, select a mobile or twitching sperm, and then inject that under high-power microscopic vision into the middle of an egg. You can see here the pipette that's used to aspirate that sperm. We use one pipette to hold the egg still, and another pipette to inject the sperm into the middle of the egg. The reason we go for the middle of the egg is we want to avoid what's called the polar body, which is a very important structure that generally sits at about 12 o'clock at the egg. Again, after the sperm is injected into the egg, and you just saw that happen there, the eggs and the sperm are left overnight to incubate, and we check whether there's been fertilization the next morning. So when the embryos are developing, we grow them in our lab for at least 5 days. So we do what's called a day 5 embryo transfer. On day 1, those arrows are pointing towards those 2 circles they're pointing towards are called the pronuclei, and that's what a fertilized egg looks like. On day 3, that's called a cleavage stage embryo, which normally has about 8 cells. And on day 5, you can see that a rim of cells on the outside of the embryo becomes what's called the trophectoderm, which becomes the baby's placenta, and that little ball of cells in the middle of the embryo actually becomes the baby, or it's called the inner cell mass. That other picture there is a beautiful hatching embryo, so you can see that it's really kind of ready to go into the uterus and hopefully implant. So we think growing embryos to day 5 is the way to go. It gives us the ability to determine which embryos have the greatest chance of success in terms of implantation. And we feel very confident at Genea offering patients a day 5 embryo transfer because we have very good faith in our culture system and our culture media, which we custom make at our clinics. This is a beautiful video just condensing 5 days of an embryo development, showing you the different stages that the embryo goes through, and really kind of makes you think how amazing this process actually is in terms of the science behind it. So you can see the number of cells increasing every minute in the embryo. You can see those cells dividing. And patients at Genea actually do have access to see their embryos grow while they're in the incubation system through our Grow app. there you can see actually the embryo hatching, which is quite amazing. So just in summary, when should you seek help? When should you go see a GP, or when should you go see a fertility specialist? Number one, you know your body best, and if you feel something isn't right, then seek help. If you're under 35 and you've been trying to conceive for 12 months, meaning having unprotected sex and you've not been pregnant. If you're over 35 and you've been having unprotected sex for 6 months and you're not pregnant. If you've been diagnosed with a condition that we know can affect fertility, such as endometriosis or polycystic ovarian syndrome. If you've had recurrent miscarriage, and by this definition we're talking about 2 or more miscarriages. If you have a genetic family condition that predisposes you to infertility, or you want to talk about pre-implantation genetic testing, or you've seen your GP and you've had preconception testing with no diagnosis. I consult out of Genea Heidelberg and Carlton. If you have any questions, feel free to contact your fertility advisors through the Genea website. Thanks for your time.